it's my pleasure to present this talk today because bacteremia and positive blood cultures, so much of what we do day to day in our institutions. We all have that in common, of course. And this is not meant to be a comprehensive talk about all things related to bacteremia because that would exceed the amount of time we have. But to make up for it, at the end of the talk, there's a list of some resources available in your pocket or smartphone, and also on our podcast site, idpodcast.net. There are great talks that you can listen to as kind of a supplement to what we're presenting today.
And also the Pathogen podcast as well, 3 episodes.
Yes. So I thought this was working.
Many.
I may have to cower around the. Let me try this one more time. Okay. So these are our objectives today. And so we have a lot to cover. So we'll get started. First of all, we know intuitively that blood cultures are among the most commonly ordered laboratory tests. And in a prior series, about 1 in 10 blood cultures are positive. And whereas in previous times, gram-negative pathogens were the most common result from a positive blood culture. Now, because of the increased predominance of intravascular devices and implanted prosthetics and other surgical procedures, then gram-positives are the leading cause. The most commonly isolated pathogen is coag-negative staph, but it can be somewhat challenging in some cases to determine, is this coag-negative staph a colonizer or a contaminant, or is it a true pathogen? And interestingly, in my research, I found that as our planet warms, we're going to be seeing some bacteremia strains more than others, such as Pseudomonas and Acinetobacter, just as a side effect of a warming climate. The impacts of positive blood cultures are pretty profound. Look at these dollar results for patients with a hospital-acquired and community-acquired Staph aureus bacteremia. This can really set back your DRGs if you're a hospital, and can increase costs overall for us as consumers and healthcare insurance holders. If you have a MRSA bacteremia or a MSSA bacteremia dialysis, which commonly happens, we see some of these consults in our facility, that can also have a profound cost. And length of stay after a positive blood culture, we all know this intuitively, can be extended by several days, a mean of 4 days or more if you have a positive blood culture. So everyone, patients, clinicians, and hospital facilities, healthcare facilities have a vested interest in reducing positive blood cultures and the onset of bacteremia. Now, since 2017, CMS has included MRSA bacteremia, for example, in its hospital-acquired conditions reporting program. So this ties the incidence of certain diagnoses to hospital reimbursement. So if you have a MRSA bacteremia, it can really be an indicator of how well your hospital is managing these different types of infections, which include central line-associated bloodstream infections, UTI, surgical site infections, and Clostridium difficile. And we know that MRSA bacteremia can lead to cancellations of procedures. It can affect line placements, can lead to increased costs in terms of antimicrobial therapy and so forth. And gram-negative sepsis can have a high mortality rate. So your patient comes in with a gram-negative bacteremia. This is a significant healthcare condition. And Staph aureus is distinct in that it tends to have the greatest long-term mortality. If you look at this, 25% mortality at 3 months, that's pretty sobering. And we see Staph aureus bacteremia very commonly. And complications of Staph aureus, such as recurrent or persistent bacteremia, endocarditis, and lack of response to primary therapy is also seen. Now, one of the things from a quality control and a infection prevention standpoint that we want to stress is blood culture collection technique. And it can vary greatly depending on where you are in the hospital and, how well trained your staff are. At our facility and others, contamination rates are tracked for quality improvement purposes. Contamination rates usually average about 2 to 3%, but they can be higher in the emergency department. Why does anyone think that the emergency department has a higher contamination rate for blood cultures? Just yell something out.
Then there's phlebotomy.
Well, it really can depend, but they can also have dedicated phlebotomists who as well.
Patients coming, taking dirt.
Right, and there may be hygiene issues.
They do.
Love that.
They do.
Yeah, I love that. Very graphic.
Yeah.
So it could be just the patient is coming in, and there could be hygiene issues, but there can also be a fast pace of the flow in the emergency department where, let me get these blood cultures and we can move the patient on. Could also be the fact that phlebotomists have among the highest rates of turnover in a hospital. I mean, if you want to get up at 2 a.m., drive to the hospital and try to draw blood from a grouchy patient, raise your hand, right? It's a underappreciated but very important job. So this can affect your the percentage of blood cultures that are contaminated. So what are some other things to think about? Well, far too often we see a single blood culture drawn. This should be avoided if possible because you really don't have any way to tell whether that's a contaminant or a true bacteremia. 2 blood culture sets are ideal, but sometimes we may draw 3 or even 4 sets of blood cultures if we want to, validate the results of a positive culture, or if we want increased sensitivity of our cultures. We do that a lot with patients who we suspect may have culture negative endocarditis, where we draw multiple sets of cultures to hopefully increase the sensitivity of the cultures overall. Blood collection quantity also matters. What is considered to be the perfect quantity of blood to inoculate a bottle?
30 ml.
I'm hearing a lot of different. I'm going to split the difference here, and it's 15, but 10 is considered adequate. And if you only have 10 cc's of blood that you can get from a patient, it's actually recommended that you inoculate the aerobic bottle only and leave the anaerobic bottle alone, because anaerobic blood cultures are so much less common. So ideally 15 cc's per blood culture, but hey, if you get 30, that's certainly enough. You can inoculate all your bottles. So this is new for 2024. I'm sure everyone is familiar with this by now. The BACTEC blood culture bottle shortage that we're currently facing at many institutions, including our own. CDC began alerting providers beginning last month, and this involves Becton Dickinson or BD bottles, BACTEC bottles. They kind of look like those little liquor bottles that you get when you're flying to Europe. And now this shortage affects the BACTEC platform only. So if you have the BACTEC platform in your hospital, you're going to be affected. But if you have other platforms like the BACT Alert, for example, then you won't be as affected. So in our facility right now, we have a workaround where our blood cultures go to one of our sister facilities for processing. And I asked my colleague, Dr. Vegas, on service yesterday, and Dr. Vegas said, well, I've only been on service for 2 days. Let me ask the fellows. So for you fellows who have been here since this shortage occurred, how are your blood culture bottles being processed? Are they Is the throughput good or is it frustratingly slow?
So
Slow.
we've got a few that are gone to pipelines, and it's just saying like it's taking forever just to resolve.
48 hours.
48 hours.
48 hours.
Yeah, it's not 48 hours.
Yeah, so that's something we really feel as clinicians, and it is definitely an issue, and hopefully the issue will be resolved soon. But my understanding is that the manufacturing difficulties are extensive, and like many other things in medicine, there's one supplier, and if the one supplier has problems, then the whole system goes down. So
So sidetrack from this thing, but why are they going to another facility if we have a bottle shortage? That's what I'm confused about.
because the other facility uses a different platform,
Okay.
and there's no bottle shortages for that platform.
So we're using those bottles.
Those
correct?
bottles?
We're using the Bacti Alert bottles that don't have a neck.
Yeah, they're not like, they're really kind of.
Yeah, they kind of look,
Cylindrical.
they're kind of cylindrical, exactly. So, so if you're just, unlucky enough to be using this system, you're affected. And my understanding is here we have a contract that extends until a certain date, and so we're kind of stuck. So, all right. So here is a phlebotomist, probably taken at 2 o'clock in the morning, where the patient is groggy, and this provider is applying appropriate antiseptic technique to get a properly collected blood culture. So you can see that they're first using an alcohol swab, then applying betadine or another antiseptic to the location, and then inoculating the bottle using a butterfly. So with proper technique, hopefully contaminated blood cultures can be reduced. But as I said, there's a lot of variability, a lot of variables in not just the technique, but also the patient that can affect contamination rates. So one approach to reduce the incidence of blood culture contamination are these so-called initial specimen diversion devices. And they attempt to reduce the potential for blood culture contamination by siphoning off the first kind of aliquot of the blood sample that's drawn from the patient, which theoretically should contain the most skin contaminants. And so I know for a time we were using this here in our facility in the emergency department. I'm not certain that we're still using it. I'm not sure what the overall assessment was for the reduction of blood culture contamination. From what I see from our blood culture contamination rates that are sent to us by email each month, it's pretty much at the same level. So once you draw the blood culture bottles, they go to what is known as an automated blood culture system. All right, so the one that we use, not necessarily the same model, is on the left, and another model called Microscan is on the right. These are just representative examples. I think there's at least 3 platforms, maybe 4, that are in use in hospitals. So back in the old days when I was a fellow, this was last century, I'll just go that far. Blood culture incubation systems were manual. So what does that mean? Well, they would draw the blood culture bottles, they would put them in an incubator. It was kind of a dumb incubator. And twice a day, the technician would come, pull the racks out of the machine, hold up the bottles, kind of hold them up to the light. If they saw any cloudiness or indication that there was growth there, they would draw a sample, gram stain it, and then work it up if it were positive. So I remember as a fellow getting called for positive blood cultures 2 times a day. It could be in the morning, could be in the afternoon. And then we would act on them. So the difference with automated systems is they have fully continuous monitoring. So they use what's known as a colorimetric disc on the bottom of the bottle. It's read by a sensor continuously. And as soon as there's a change in the indicator, the blood culture system, announces that, reports it to the technician. The technician pulls the bottle, does a gram stain, and goes from there. So this detection is very reliable. It doesn't require on subjective human error. It uses a monitoring sensor. It continuously reads. So now you can get a positive blood culture called at any time, 2 o'clock in the morning, in the middle of your workday, whenever. And so these automated blood culture systems really help, and they provide a much more rapid indicator of when blood cultures are growing. And blood cultures are not cheap, so keep that in mind when you order them, right? I mean, the cost of each blood culture can be as high as several $100s. So when you order those 2 blood cultures, you could be adding $800 to the patient's bill. Now, a recent development that's really helped our management of positive blood cultures are so-called rapid detection systems. And perhaps the first of these that we began to use in our facility here is known as the Maldi-TOF, or the mass spec machine. So how does a mass spec machine help with the rapid detection of a positive blood culture? Well, the typical way of processing a blood culture involves obviously collecting the sample, incubating them in that machine that we just talked about, and then when the blood culture is called positive, when there's evidence of CO2 growth within the bottle, a technologist pulls out a sample and gram stains it. If the gram stain is positive, that's called to you, the clinician. And then pause for just a second.
More times?
It's fire.
Much better now.
We have to do the Spanish show. All right, so they don't do that anymore, but they used to. All right, so so once the gram stain is positive, the specimen is placed on subculture, right? And then when you have the gram stain from the pure culture, it would go for biochemical identification. That could be anywhere from 6 hours to 5 days. So the difference with Maldi-TOF, with the mass spec machine, is they can pull the specimen from subculture. So the organism has to be subcultured first, and then they can put it on the Maldi-TOF machine, and using laser scattering from shooting a laser at the bacteria in a time of flight, so to speak, they can very accurately identify the bacteria much more quickly. The mass spec can identify an organism in as little as 10 to 30 minutes. So you don't have to go through the biochemical identification, but you still have to subculture the organism. And then you have your final identification. Now, so those are the positives of the mass spec machine. The negatives are that you still have to subculture, so that adds a delay. And also, for different institutions, not all organisms are validated for use on the mass spec machine. So there may be some organisms that you can identify using the mass spec machine, and those, as we know from our experience, still have to be sent out for biochemical identification. So we're not able to get ultra rapid identification with the mass spec machine. And so the next development, the development that really, I think, enhanced our blood culture identification was so-called rapid detection systems, multiplex PCR identification. Because the advantage with these machines are that you can identify a blood culture isolate if it's within your panel, right from when the gram stain is called. So, and that identification can occur in as little as 1 hour. So you get a positive blood culture called 1 hour later, theoretically, you have your organism identified. So the panel that we use here is the BCID2, and all of you are familiar with it, of course. This identifies 43 targets including 26 bacteria, gram-negative and gram-positive, 7 yeast, they're listed there, and 10 antimicrobial resistance genes. So this has really enhanced our management of positive blood cultures for a variety of reasons. If you know, for example, that gram-positive cocci in clusters is a staph epi versus a staph aureus, you can make really important real-time decisions about antimicrobial management. If you know the resistance genes present in a member of the Enterobacterales that are identified, it can help you determine whether you need to escalate your coverage appropriately. And so it can also differentiate, for example, if you have a positive blood culture for budding yeast, whether those yeast are candida or whether they could be Cryptococcus, for example, and that's important too. So right now, my understanding is you have to, for our facility, the blood culture bottle shortage adds to the delay in the processing of blood cultures. So for this to be most effective, you have to have a working blood culture system with adequate bottles in your facility. So hopefully we'll be back on track and be able to use this. My understanding is at our sister facility, they still do the BCID, right? So you guys been getting BCID back with your blood culture results, but it's from our sister facility. Yeah, it starts with the initials are BP. But for the interest of the podcast here, I will not mention what that facility is. All right, so let's talk about the assessment of positive blood cultures. What do you do when your blood culture is called positive? So you have to ask yourself some basic questions. And forgive me if this is remedial for some of you, but let's talk about it and kind of fortify our memories about what we do. So the first question you have to ask yourself: there's a positive gram stain of a blood culture isolate. What are the gram stain results? Is it a gram-positive cocci, gram-positive rod, and so forth? And is it a single bottle or are there multiple isolates? Obviously a single bottle is much less likely to be a true positive than a blood culture result where multiple bottles are positive. But on the other hand, there are some bacteremia pathogens that even a single bottle you want to take seriously. So is there growth on the aerobic bottle or the anaerobic bottle? Now, sometimes that can be misleading because aerobes can grow in anaerobic bottles. So just because you have a positive anaerobic bottle doesn't necessarily mean it's an anaerobe. Also, what is your collection source? If you have a single bottle positive for coag-negative staph or staph epidermidis, you might ask yourself, where was this collected? What body site? And if you can look at that body site on the patient when you go to evaluate the patient, maybe this was a patient that had some hygiene issues or just had very thin atrophic skin, like many of our older patients have, where they're heavily colonized with coag-negative staph, and as a result of a very hurried collection, you can get a positive blood culture bottle. Also, a useful metric is the time from collection to positivity, because if you get a positive blood culture, let's say within 6 hours of collection, the inoculum, the amount of bacteria in that culture, is going to be much higher for it to be for the growth to occur so quickly, versus a blood culture, for example, on the other end where you get growth reported after 18 hours in a single bottle. That sounds to me like a very small inoculum, and that's much more likely to be a contaminant. You want to think about these comorbidities associated with bloodstream infections, particularly those who are very immunocompromised, like stem cell transplant patients, those on CAR T. My colleagues talked about that last hour. Patients with high-grade neutropenia, AGC of less than 100, but also chronic illness, TPN, and extremes of age on the left-hand side of the slide. Also, you want to know the circumstances of collection. Was this collected on the floor? by experienced nursing provider, or was it collected in a very rapid collection pressure in the emergency department or in the field or whatever? Also, does the patient have a prior history of bacteremia? Because we know that patients with prior history of bacteremia tend to have bacteremia recur. I always like to look at the chest x-ray because, it's an easy way to see if they have an intravascular device or a pacemaker, which could result in a complicated bacteremia, or it could be a focus. We see a lot of burn patients at Tampa General. Does your patient have compromised skin or GI integrity that can lead to bacteremia? Stevens-Johnson syndrome, burn patients, anybody with interrupted mucosal barrier. Sometimes here we see patients with severe pressure-related wounds. Any break in the skin can be an entry point for bacteria and can lead to bacteremia. So we've seen that the collection of blood cultures right now is even more, we need to use even more discretion than ever before, because we have we have shortages of blood cultures. The results aren't going to be back right away. So I like to think about the pretest probability of bacteremia. If we're going to ration our blood cultures as we're doing right now, which patients are most likely to be positive, which are maybe moderate, which scenarios are low likelihood, low pretest probability of bacteremia. So these are the high ones. If you have a patient with discitis, vertebral osteo, epidural abscesses, meningitis, septic shock, or an intravascular catheter, the pretest probability that they're going to have a true bacteremia is much higher. So think about these patients when you order blood cultures. How about those with more moderate, but still significant pretest probability of bacteremia? Patients with cellulitis with severe comorbidities, patients with pyelo or cholangitis, pyogenic liver abscesses, severe sepsis, somebody who is having rigors, they're likely to be bacteremic. So if your pyelo patient is having rigors, think about, hey, we should check blood cultures in those patients. So I think this is probably the most important of these three slides. Which patients are unlikely to have bacteremia? And we know when a patient has a low pretest probability of something, it means that their false positives are much likely to be higher when a positive occurs. So if you have somebody with uncomplicated cellulitis, a cystitis, a community-acquired pneumonia, or healthcare-associated pneumonia, somebody who's within 2 days of surgery with a fever, or somebody just who has an isolated fever, 100.5, and then they go back to being not febrile any longer. Those patients are probably not going to have positive blood cultures. And then if you order them anyway and you get a positive back, and you have to kind of feel, well, what am I going to do with this? So what are the characteristics of a true positive blood culture? When you have multiple pathogens in a blood culture, it's much more likely that it's contaminated. We've had those patients that they get a blood culture and they grow bacillus, coag-negative staph, and corynebacterium. That sounds to me like in a single blood culture, that's a contaminant. If you have a single pathogen, like let's say E. coli or Staph aureus, that's more likely to be a true positive. And you also need to take seriously pathogens that are typical bacteremia pathogens, like Staph aureus, Streptococci, Enterococci, Enterobacterales, and so forth. And if you have multiple positive cultures, you order blood cultures on day 1, and then on day 3 you repeat them, and they're positive for the same organism. I think we all realize that's highly significant. How about patients with risk factors? Somebody with an intravascular catheter, a patient with an abscess or a discitis, and they have a positive blood culture, that's highly significant. On the other hand, if you have prolonged time to culture positivity, if you have the presence of bacterial strains that are more seen in contaminants, And if you have the absence of systemic symptoms, you're more likely those are false positives. Here, I always look at the patient. So the patient, I ask them, where were your blood cultures drawn? I look at that site. If it looks like there's multiple sticks in that site, they have a lot of ecchymoses on their arm where the blood culture was drawn. You know, those are all suspicious warning signs that maybe a positive blood culture for coag-negative staph is not significant. So if you see any of these blood culture pathogens, they're frequently contaminants. But I want to call out the very last one on the list, which is to say that virulent streptococci can be contaminants, but they can also be true pathogens, obviously. So that one I would take a little bit more seriously and maybe do a little bit more investigation into whether it's a positive. Obviously, if you have a single bottle positive for a virulent strep, that's less significant than if you have 4 out of 4 positive. On the other hand, the following blood culture pathogens are not usually or never contaminants. So look at these on the list. If you see them in a blood culture, take them seriously. You know, obviously Listeria, you should always take seriously. Candida species, Cryptococcus, obviously, the Enterobacterales, Pseudomonas, Bacteroides, and so forth. So keep those on your list. Let's talk, just add a little bit of color or flavor to our discussion of specific gram-positive pathogens of significance. Coag-negative staph, you know, obviously, those are high on your list of possible contaminants. But if you have a patient with an intravascular device, a prosthetic valve, or another hardware, and you have 4 out of 4 bottles positive, or if you have persistently positive blood cultures, that's real. So certain other coagulase negative staphylococci like hominis or conii, those coag negative staph, usually much less pathogenic, more likely to be a contaminant. Staph lugdunensis, I'm sure most of you or all of you know this, has certain characteristics that cause it to have similar pathogenicity to Staph aureus. So if you see a lugdunensis, treat it like a Staph aureus. For Staph aureus, it seems like the trends in recent years has been a return to MRSA being a hospital pathogen and MSSA being a community pathogen, whereas maybe 10 or 15 years ago, the opposite was true. In other words, we're seeing a lot more community acquired MRSA, and so the distribution was different, but at least in my subjective review of what we see coming into our hospitals, we see a lot of MSSA again these days. And that may be the result of good antimicrobial stewardship. You guys, most of you guys are new in your ID career, but there was a time in ID before antimicrobial stewardship programs, and it was much more of a Wild West than it is now. So thankfully, antimicrobial stewardship is an integral part of what we do these days as ID clinicians. Streptococci, Dr. Baluch and Klinkova talked about how significant a pathogen that can be in immunocompromised patients. You want to take virulent streptococci seriously, of course, if you have an intravascular device, prosthetic valve, or if you suspect your patient could have endocarditis. Enterococcus species, generally speaking, Fecalis is much more virulent than Fecium. Fecium tends to be more prevalent in patients with extensive exposure to antimicrobials. It's much more of a significant factor when you have indwelling devices. Fecalis tends to cause bacteremia, can be more of a urinary pathogen. It's a little more controversial, but what do you do with let's say, a single positive blood culture bottle for Enterococcus fecalis? You know, should that be treated in an asymptomatic patient where you do repeat blood cultures and it's negative? I think many clinicians would say maybe treat that as a contaminant and not necessarily subject the patient to antibiotics. And our Enterobacterialis, of course, are very significant. We see a lot of resistant Enterobacterialis infections with AMP-C, ESBL, CREs, and so forth. So all of these are significant pathogens. How many people are familiar with the modified Hodge test? This was a old-timey way of determining the presence of carbapenem producing Enterobacterialis strains. Which one is positive for CRE? This one, or this one? Does anybody know? That's an ertapenem disc in the middle. And there's a lawn of bacteria there. So obviously it's this one because you can see the lawn going right up to the ertapenem disc. So that's some trivia. Maybe you'll get that on a board exam. I don't know. If you see any of these bacteria, it should raise alarm. Clostridium species, obviously, you need to rule out maybe a crush injury or a GI source. Can you have Clostridium difficile bacteremia? Yes, you can, right? How many people, anybody seen a C. diff bacteremia? Yeah. If you see Strep galolyticus subspecies, galolyticus used to be called Enterococcus bovis or Streptococcus bovis. That's associated with GI cancer. Burkholderia, if you get a positive blood culture for Burkholderia, remember there's Burkholderia pseudomallei, which is kind of a unusual pathogen. You definitely want to notify your microlab, the etiologic agent of malleodosis versus Cepacia, which is more of a hospital pathogen. And Listeria species, in recent weeks, we've heard about Listeria outbreaks related to deli meat and to ice cream and so forth. So think about Listeria species. Take that seriously. If you have a positive blood culture, that's definitely abnormal and it needs to be treated. About 15 years ago, we wrote up a case of a veteran who came in. He had vascular grafts, and he visited a local taco establishment and ate some soft cheese there. He got a Listeria bacteremia, thrombosed his grafts. So Listeria bacteremia, not just a significant cause of GI illness, but also can have serious complications, particularly in these risk categories: immunosuppressed, elderly, and expectant moms. So more on the practical management of a positive blood culture, just to reiterate that you want to first establish if it's true bacteremia versus a contaminant. Here's a patient with a ecchymosis on their arm. You might even be able to make out some venipuncture sites on the arm. This is the typical patient that would have a positive blood culture for coag-negative staph. They're just a hard stick. Their veins are not very cooperative, and it may require several sticks with the venipuncture to get your specimen. And and also, sometimes you'll be cruising along in your hospital and the blood culture contamination will be low, and then maybe the staff turnover occurs. Maybe it's summertime, or maybe there's pressures in the hiring market. Unemployment's low. People are doing other jobs, and they train a whole new number of people, and you get more false positive blood cultures just until people are trained. So there can be a variety of factors. If you think it's a true bacteremia, you want to assess for sources. Where did this come from? Here's a patient on the bottom with a lot of skin integrity issues. That can be a source of bacteremia. Here's a person on the top who's getting their Foley manipulated. Could they subsequently develop a hospital-acquired urinary tract infection and develop a bacteremia? Look for GI and GU processes. Sometimes patients need, further imaging to look for a source of bacteremia. I remember in my fellowship, there was a patient who had a persistent bacteremia, and he had the whole workup. He had CT imaging. He had an exhaustive examination. He had he had a bunch of different tests. Turns out he had a rectal abscess that couldn't easily be seen by CT scanning. I think it was picked up by a nuclear medicine scan. So sometimes it's not immediately obvious what the cause of a bacteremia is. You have to look further, and that's really what we do best. You want to determine the need for treatment. Again, gram-negative endotoxemia, gram-negative bacteremia, particularly an immunocompromised patient, has a high mortality. Those patients, you don't necessarily want to wait. You want to cover them immediately, even if that involves broad spectrum coverage. You can always narrow that coverage as soon as possible. Staph aureus, sticky pathogen. My patient have a pacemaker and prosthetic joint. You want to examine them for signs of septic arthritis too. I remember in last week's talk, which unfortunately couldn't be live, our speaker saying, if you have a patient with Staph aureus bacteremia, look for septic joints, even if they're sternoclavicular joints. That's a suspicious sign for endocarditis. Pseudomonas aeruginosa also has high morbidity from infection and needs empiric treatment. If it's a true bacteremia, address the underlying focus. Remember, a lot of causes of persistent bacteremia are what? Source control, right? Has my patient's source of bacteremia been addressed? If it hasn't been addressed, you can escalate the antibiotics infinitely, and they're not necessarily going to clear. You may find the occasional patient that has a septic thrombophlebitis as a cause of persistent bacteremia too, so be on the lookout for that. Now, I'm not going to spend a lot of time in this talk talking about specific antimicrobial agents because, as my colleague Dr. Cancio said last week, it doesn't really matter what you start the patient on as long as it's appropriate. It covers the selected pathogen and you use your good judgment. So, so apply your knowledge and experience with infectious disease and how to treat pathogens. We can always look that up, right? Common sources to look up how to treat a bacteremia, the Sanford Guide, John Hopkins Guide, up to date, ask a colleague, and so forth. But when you're starting out, broad spectrum antibiotic therapy may be needed until you get your blood culture results back. And I was gonna say in this lecture, now we have our blood cultures are called positive. We have BCID. We can get that answer back in an hour. So that greatly helps in terms of how broad our spectrum needs to be. But right now, our blood cultures are being delayed by 48 hours. So you may need to cover more broadly. You want to tailor the antibiotic to your specific pathogen. And you want to use pharmacokinetics to your advantage. Here at our facility, we have great infectious disease clinical pharmacists who can help guide us on how to use pharmacokinetics to our advantage. If we have a less than susceptible Enterobacterales, still be covered by cefepime, for example, and where we use more smart dosing strategies in order to make the antibiotic more effective. And some antimicrobial classes are preferred in bacteremia more so than others. For example, glycopeptides like that, vancomycin, beta-lactams, carbapenems. The less ideal ones are perhaps not optimized for bacteremia for one reason or another. Maybe they don't get good intravascular levels. Maybe they're more peripherally migrating antimicrobials that go to the tissues more often. Maybe they have pharmacokinetic properties that don't make them advantageous to get good persistent levels within the intravascular system. So there are definitely better antimicrobial classes for bacteremia than others. And then something that I often struggle with, this is kind of the number one reason that I look something up, is the duration, right? I mean, if you look at overall duration of antimicrobial therapy, most of the time it's not really validated. It's expert opinion for a lot of different types of conditions. So, for most bacteremias, we can get a generally good idea of how long to treat. If you have a Staph aureus bacteremia, usually 2 to 6 weeks. But what if you have an Enterobacterales bacteremia? Is that shorter? And also these days, I think there's a philosophy about shorter is better. And also there's a philosophy about when can I switch my patient from IV therapy to PO? Is that ever an option? Because there's obvious advantages to PO therapy. So I like to refer to my colleague, I should say our colleague, Brad Spellberg, and this is a website you can go to where he argues that shorter is better. And he also argues about how we can consider oral therapy in certain cases when we have a bacteremia. So I've highlighted gram-negative bacilli bacteremia and how recent data favors shorter courses of treatment. There's been at least 3 randomized clinical trials that Dr. Spellberg talks about where a shorter course of therapy of only 7 days is non-inferior. So you'll find your attendings opting for 7-day courses of therapy for gram-negative bacilli bacteremia in many cases because of these clinical trials. And if you have a highly bioavailable agent like a quinolone, for example, and you can switch a patient to oral therapy to complete their course of therapy, you do a lot of advantages to the patient. They may be able to be discharged sooner. You may be able to remove their intravascular device more quickly, and you make therapy more convenient, and also it's more cost effective. So those are things to consider. What are some specific considerations for specific pathogens? Well, remember, if you have pneumococcal bacteremia, that tends to be very exquisitely sensitive to antibiotics, and you may only need a short duration of therapy, maybe 5 days, for example. Enterobacterales, as we've said, 7 to 14 days. There may be risk factors for AMP-C, ESBL, CRE resistance. Do you need an empiric carbapenem? Hopefully, when we get our BCID online, you can have that information back very quickly. Is there an indication for an aminoglycoside? And when do I need to repeat blood cultures for clearance? Well, in more recent years, it's become accepted that maybe you don't need to repeat blood cultures for gram-negative rod bacteremia. There was a recent study I recall where they looked at 500 cases of gram-negative bacteremia in patients who had repeat blood cultures, and the incidence of repeat positive blood cultures in patients who were started on therapy was actually very low. I think it was 8 out of the 500 cases, if I'm recalling correctly. So it's oftentimes not necessary to repeat blood cultures if you have gram-negative bacteremia where you believe the source has been addressed and the patient's responding to therapy. Pseudomonas, 2 weeks minimum, IV preferred. The activity for bacteremia of quinolones is not really ideal. So I think switching a patient to a quinolone for the treatment of Pseudomonas bacteremia, even for a partial part of that 2-week treatment course, I think is not usually a preferred strategy. And remember that Pseudomonas can be a potential endovascular pathogen. When you treat Staph aureus bacteremia, is this a primary bacteremia or a secondary bacteremia? Always want to ask your patient, how's your back? Are you having back pain? Because a lot of patients with Staph aureus bacteremia, at least in our facility, will have an associated discitis or osteomyelitis, more than you would be surprised to learn about. So think about other foci of a Staph aureus bacteremia, not just an isolated bacteremia itself. Is it an uncomplicated bacteremia? Somebody have a line in, they got a Staph aureus bacteremia, you take the line out, they have a single positive blood culture, no subsequent positives. That's an uncomplicated case versus anyone who has a repeat positive blood culture for Staph aureus, that's a complicated bacteremia. So more than one set of positive blood cultures, complicated bacteremia, needs longer therapy. Do they need imaging? Do they have indwelling devices? Here at our facility, ID consultation is automatic. So you all will get to see all the cases of Staph aureus bacteremia because we recognize how much value we add to the equation, how we guide therapy, and also make sure that patients are on appropriate treatment and they're treated for an adequate duration. Virulent streptococci, generally a low virulence pathogen except in patients who are severely immunocompromised. You should carefully evaluate for an oral or skin soft tissue source. 2 to 6 weeks therapy usually required if their bacteremia is true. For enterococci, what are the portals of entry? GI, urinary. I talked previously about the significance of a single positive blood culture, so keep that in mind. A single positive blood culture for Enterococcus faecalis in a patient who doesn't have an intravascular device, who doesn't have clinical symptoms consistent with a bacteremia, you may be able to discount and avoid having to treat them. Enterococcus faecium, hospital-acquired pathogen, often resistant to vanco and beta-lactams. Also remember the role of biofilms to Enterococcus infections and how it may be difficult for you to eradicate enterococcal bacteremia on a prosthetic valve, for example, in somebody because of biofilms. Further source control may be needed. Anaerobic bacteremia, the presence of a positive anaerobic bottle doesn't necessarily mean it's an anaerobe. There are gram-positive anaerobes and gram-negatives. Keep in mind that differentiation, and you always want to look for a mucocutaneous GI or genitourinary source. So these patients may need imaging to rule out a pathogen. And what about endocarditis pathogens? Think about these, all of these pathogens may cause endocarditis, and you need to work that up. A TE may be necessary, and sometimes the involvement of your surgery colleagues. Long a point of debate is when is double coverage needed for bacteremia. Sometimes if you don't know the identity of a bacteremia and you have a patient with a history of more resistant gram-negative bacilli, you may need to add a second agent for a couple of reasons. Number one, maybe they're severely septic and the addition of aminoglycoside may clear the bacteremia more quickly. But also, if you don't know whether resistance is present, if you have two agents on board, it's more likely that one of those agents will have activity in a serious case of bacteremia. But of course, once you get the identity of the gram-negative organism back and you know the susceptibility panel, then of course you can de-escalate very quickly, because having that second agent on board for long periods of time in most cases may not necessarily add to the therapeutic efficacy of your regimen. And then you have your cases of bacteremia with these organisms where you're treating an endocarditis and you have a more resistant strain, and where the recommendation is to use double coverage, right? So that's the other circumstance. So obviously you want to narrow based on susceptibility results. And in many cases, if a patient is clinically improving, you have achieved source control, they can absorb and take oral antibiotics, there's no contraindications, then you can consider an oral agent with excellent oral bioavailability. These are post-treatment considerations. We always can do more with prevention than we can after something has already occurred. So you always want to minimize the use of unnecessary lines, put that in your consult, eliminate unnecessary implanted devices. If there's an endovascular source, most of these patients may eventually go to valve replacement, but you'll find that a lot of times if you're a surgeon, it's not that ideal to go in when a patient has endocarditis and replace a valve. You can sterilize that valve as much as possible, and then several weeks down the line, when the situation is better controlled, the surgeon can go in and replace the valve. There's a much lower incidence of complications, and they like it better. So all of these lectures are on ID podcasts, and they relate to the subject of bacteremia. So I'll try to forward my slide presentation to you all as well. So you can just click on these and you can read about a lot of different topics related to bacteremia. So use ID podcasts as a great resource. We have now hundreds of lectures on there over the years. Some in topics you would otherwise not even think we would have topics on. And you know what? A lot of those lectures and ID podcasts are from fellows. So you can see the great work that that your fellow colleagues have done over the years in producing outstanding lectures that help people, not just in our community, but literally across the globe. And then I mentioned these resources in our talk, and most of them are available now for your smartphone. So if you're like me and you can't read a small book anyway because you have presbyopia, and
I can't read it.
you can pinch and zoom on your smartphone. Okay, now I see that. That's what I do each and every day. And then yes, I want to share our Contagion Infectious Disease podcast, including our most recent episode was released last week with my colleagues, Dr. Sherbuck and Dr. Vega, do a really great job providing the content for our podcast series. And we hope to work with everyone in the room here in the future for contributing to this great project. And with that, here's my summary, and I'll take any questions.